Welcome to this special edition of Diabetes Core Update, where we discuss diabetes and hypercortisolism. If you didn't listen to our first two podcasts of this series, you might be asking yourself, why are we discussing hypercortisolism? It is vanishingly rare. In our first podcast, we discussed that the Caviness study showed that in people with uncontrolled diabetes, the prevalence of hypercortisolism is approximately 24%. Now, that was surprising to a lot of us. In our second podcast, we discussed the treatment of hypercortisolism. Don't worry if you missed those podcasts. We'll review most of that information again today, but today we're going to do that in the context of cases and evaluating a patient in the office. This is really important new information. I'm your host, Dr. Neil Skolnik, professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. And this special series of Diabetes Core Update is sponsored by Corcept. Joining us for today's episode is Dr. John Buse. Dr. Buse is the Verne S. Caviness Distinguished Professor and Director of the Diabetes Center at the University of North Carolina Chapel Hill School of Medicine. He has been President for Medicine and Science at the American Diabetes Association, is a recipient of the ADA Outstanding Achievement in Clinical Diabetes Research Award, has authored more than 500 publications, and participated in and led numerous clinical trials. John, welcome back.
Thank you very much. It's great to be here.
Also joining us to present a primary care point of view is Dr. John Anderson. Dr. Anderson practices internal medicine and diabetes at the Frisk Clinic in Nashville, Tennessee. He has served as a past president of the 38-member multi-specialty clinic, has served leadership roles at Centennial Medical Center, a 670-bed HCA tertiary care referral hospital. He has served as chair of the Department of Medicine for 2 separate terms. In addition, he served 2 separate terms on the National Board of Directors for the American Diabetes Association, and in 2013, he received the Banting Medal for service as President of Medicine and Science for the ADA. John, welcome.
Neil, John, thanks. Great to be here.
John Anderson, I'm going to throw you the first question. Helping patients with diabetes get to their A1C goal can be challenging for us in primary care. Let's start with a case, and that is a 54-year-old woman with type 2 diabetes for 10 years. She also has obesity, hypertension, hyperlipidemia, and depression. She's on metformin 850 BID, glipizide 10 milligrams daily, and empagliflozin 10 milligrams daily for her diabetes, as well as lisinopril 10 milligrams a day, atorva 40 daily, and escitalopram 10 milligrams daily. On physical exam, her blood pressure is 134/82, her BMI is 33, and her physical exam is otherwise unremarkable. Labs show normal renal function, her UACR is normal, but her A1C is 9.2. What things do you think about? And John, how do you approach this case?
Well, Neil, thanks. The first thing you notice is that her blood pressure is under a relatively reasonable control with a very small dose of an ACE inhibitor, which is not usually the case, especially in someone with a BMI of 33. But the thing I'd like to know is, let's just go back 10 years. This lady was only 44 years old when she was diagnosed with type 2 diabetes. So she, at the young age of 54, now has a 10-year history of this disease. And what I don't know from what you presented is, how long has her A1C been this high? Was she under control at some point in time and then has lost control? Has her weight been under control and at some point in time has gotten worse? But clearly, she has weight challenge goals, and she has challenges in getting what is a relatively high A1C, less than that ADA recommended 7.0 for someone her age, maybe even more aggressive goal than that. As I look at this person, the first thing that comes to mind is, what about the most potent medications we have? What about a GLP-1 receptor agonist? What about a GLP-1 dual combination with a GIP receptor agonist? This woman needs significant A1C reductions as well as help with her weight. And I think that's the first thing that I would come to. I'm not a big fan of glipizide and sulfonylureas, and that's a whopping dose of a sulfonylurea as well. So if we were really going to start her on one of those two agents, I probably would let the sulfonylurea disappear into the ether along with it. And honestly, I'm probably not thinking about hypercortisolism just out of the gate with this, as we haven't used some of the more potent medicines yet.
I think that's a really important point, and I think a point that I don't want lost on our listeners, as we are so enthusiastic about the new information about hypercortisolism, is that it doesn't mean that we're checking for this on everybody, that it's always back to fundamentals first. Here, getting rid of that sulfonylurea, as you said, makes a lot of sense. Adding a GLP-1 or dual agonist makes a lot of sense. So let's follow this case along. And her glipizide was stopped. Semaglutide was started and titrated to the goal of 2.4 milligrams weekly. The titration period, it turns out, took a little bit longer than planned because she was having side effects initially. She had imperfect follow-up, which I'll say is not that unusual. And by a year later, she's on metformin 850 BID, empagliflozin 10 daily, semaglutide 2.4 milligrams weekly, as well as the other medicines that were mentioned, lisinopril, atorvastatin, citalopram. And on that regimen, her A1C had come down, but not to goal. So at this point in follow-up, her A1C is 8.2. And John Anderson, still, your thoughts at this point?
First of all, it's a pretty real-world scenario, right? How many times does life get in the way of our follow-up for our patients? Did she have formulary issues? You said she may have had initial side effects. Did she stop it for a while? But somewhere along the line, somebody has been doing a dose escalation, right? Because she's gotten from what one would assume is a 0.25 all the way up to a 2.4 milligram dose, which is the highest dose of injectable semaglutide. And yet you look at that high baseline A1C of 9.2, and she's only dropped 1.0. Yes, it's better, but it's not what one would expect. And I would ask, because you didn't mention, did she lose weight as well? At this point in time, if this is my patient, she is quickly entering that realm of what in the world am I missing here? Assuming that we've talked about adherence in a non-judgmental way, are you able to afford these medicines? Are you able to get them? What's your day for injecting the semaglutide? A lot of my patients are Sunday or Monday morning injectors. So if you're confident she's being adherent, filling the prescriptions, at this point in time, she, in my mind, is an outlier. She's not responding to the best therapies that we have. And so is this a patient for whom we should be checking for hypercortisolism? And I would say, yes, this is a patient I would clearly choose to address that issue or the potential issue.
And John Buse, your thoughts at this point?
Yeah, I agree with the formulation as you guys have discussed. In the Catalyst study, the study that sort of opened this issue to our understanding, we had as the inclusion criteria people with a A1C between 7.5 and 11.5 who were either on 3 drugs for diabetes, or they were on 2 drugs and one of them was insulin, or they were on 2 drugs and they had complications of diabetes, or they were on 2 drugs and at least 2 drugs for hypertension. So she would have qualified for the Catalyst study. And in my mind, anytime you think about whether a patient is not being adherent, you should at the same time think about that they might have hypercortisolism, because I think that's basically the differential diagnosis here. And the truth of the matter is she got a 1% reduction in A1C, which is not what you'd expect, but we did stop her sulfonylurea, so maybe she gets a little bit of credit for that. But it's an easy test to do. It gets you an answer. It's not very expensive. And if she does have hypercortisolism, it's a game changer as far as the approach to diabetes management.
It's interesting. As I listen to this case, my ordinary response before the date on hypercortisolism would have been looking at her, thinking a lot about adherence, and then probably adding basal insulin, which is, I think, for most of us, that next step after the GLP-1 doesn't work. Not a wrong step, I don't think, but I mention that because it's so easy to do that and skip over thinking about hypercortisolism unless it's in the front of our mind. Does that make sense?
Yeah. And, what I would say is you start her on insulin. You titrate up some basal insulin to 40, 50, 60 units, and her A1C is still 7.3. Then you can think about hypercortisolism. So you don't have to think about it today, but don't forget about it. It's actually a pretty common abnormality, at least in the study that we did.
Yeah, I thought that was amazing. And while there were a lot of criteria you went over, John, I think for me and for many in primary care, and John Anderson, I'd be interested in how you remember who to check for hypercortisolism. It's people who are on multiple medicines and not getting to goal like we'd expect without having to define it very precisely. John Anderson, any thoughts you have on that?
Yeah, I think so. And to your point, starting basal insulin, someone with a BMI like this, it'll help with glycemic control. It may not help her feel much better, that's for sure. And then there are other things. I'd like to know about her depression. We know that these people with hypercortisolism have a variety of other sort of issues, difficult to control blood pressure, kidney stones, depression and mental health issues. It'd be interesting to know where she is with her moods and that type of thing. So there may be other non-glycemic things you look for as well in primary care that would jar your thought process and say, maybe this is someone who needs to be tested.
That's a great point. Dr. Buse, any specific other factors that showed up in the study that were associated with an increased likelihood of hypercortisolism?
Yeah, the most interesting and unexpected bit was that the people that were less heavy actually had a higher risk. So it's not the massively obese patients with diabetes that are particularly high risk for this hypercortisolism. It's the person who's very difficult to treat, but they're actually not that heavy. So a BMI less than 30 specifically doesn't mean you shouldn't check in someone with a BMI of 35, but that's just the probabilities. The other things that turned out to be positive predictors are people that had an A1C greater than 7.5 despite the use of tirzepatide or the highest dose of other injected GLP-1 receptor agonists, people who were taking fibrates, people on multiple blood pressure medicines, people who were treated for depression or anxiety or other neuropsychiatric problems, people who were treated for pain and were taking analgesics. So the general burden of disease, the multimorbidity is the major feature, and frankly, the number of medications.
Fascinating. We decide to go ahead and test for hypercortisolism. Can you remind us of how that testing's done?
Yeah, in the Catalyst study, what we did was the overnight dexamethasone suppression test. That's where you prescribe a 1 milligram tablet of dexamethasone. The patient takes it at 11 p.m. They come in the next morning to have a morning cortisol drawn, ideally between 8 and 9 o'clock in the morning, certainly no later than that. And then you have a reflex order that if the cortisol is greater than 1.8, which is the cut point we use for hypercortisolism, then you should measure a dexamethasone in the same sample. And that's to ensure the patient took the dexamethasone tablet, absorbed it, and is not a super metabolizer of dexamethasone.
So it's not a hard test for us to do in primary care. And John Anderson, have you ordered that test some and it ends up working okay? Patients are able to take their dexamethasone at night, get to the lab, et cetera.
Yeah. The only issue is if you have someone who's 30 or 45 miles away, you may need to do it, see if you can find it done locally. But patients are perfectly willing to do this. Again, you're also having that discussion with them. Like, you're frustrated. You don't feel well. I'm frustrated. Let's check on this parameter and see if this is something that will open our eyes to a better way to treat you. Well, if you give the patient that opportunity, taking a pill at 11 o'clock at night and being at my office at 7:45 or 8 in the morning is just not that big a burden. Like in primary care, we do a lot of things. We do a lot of mammograms. I would dare say a mammogram is more than that. I would say colonoscopies are more than that. So if you frame it correctly for the patient, they're very anxious to have this test done and see if there's something we're missing.
That's a great point. So we do the overnight dexamethasone suppression test. Most of the time it comes back normal, but as we were talking about 25% of the time, maybe more depending on someone's other risk factors, it comes back with a cortisol level greater than 1.8. And so that indicates that persistently high cortisol levels are likely contributing to the person's hyperglycemia. Dr. Buse, can you remind us what the next steps are in that person's workup?
Yeah, and here is where there's a little bit of controversy. What we did in the Catalyst study was to use a very sensitive test, the overnight dexamethasone suppression test. And the only follow-up testing we did is on a separate day after we got the results back. If the morning cortisol was greater than 1.8, was to do a morning ACTH, DHEA sulfate, and a cortisol. And that is to confirm that this is ACTH independent disease. So the ACTH and DHEA sulfate should both be below or near the lower limits of normal for the assay. And we did an adrenal CT, an abdominal CT, but you could order a specific adrenal CT for greater sensitivity to evaluate whether there was an adrenal nodule, mostly because in that setting, surgical therapy is a possibility.
Okay. How often were adrenal nodules seen in that population?
A solitary adrenal nodule was seen about a quarter of the time. Some adrenal abnormality, thickening of one of the limbs, or maybe nodular disease or thickening in both adrenals. Overall, the total proportion of people with something wrong in an imaging study was about a third of patients.
Okay. So 2/3 of people had an elevated cortisol level after an overnight dexamethasone suppression test, no evidence of adrenal nodules. In that group, what's done?
Well, in this clinical trial, we randomized people 2-to-1 to get mifepristone, a cortisol receptor antagonist, or placebo. We started with 300 milligrams a day, and if tolerated, they went up to 600 milligrams, and if needed and tolerated, they went up to 900 milligrams. We followed them for a total of 24 weeks, and what we saw at the end of 24 weeks was a 1.5% reduction in hemoglobin A1C with mifepristone from 8.6 to around 7.1, and about a tenth of that reduction in hemoglobin A1C in the placebo-treated patients. We saw basically the same results in people who had normal adrenals on imaging and people who had nodular disease. And we also saw about a 5-kilogram weight loss, which the weight was still going down at 24 weeks. So we don't know with longer follow-up what we might expect with regards to weight loss.
Okay, fascinating. Really seem to make a difference for those people. Dr. Anderson, any real-world challenges that you anticipate with looking for and then treating hypercortisolism in patients with uncontrolled diabetes?
Yeah, just to follow up on one thing John said, you know, this 1.5% A1C reduction, that's only 24 weeks. And like you said, the 5-kilogram weight reduction, you know, what I would be fascinated is a longer term follow-up at 1.5 to 2 years. And what's the real world benefit that, you know, that you'd have an ongoing relationship with this patient that's well beyond 24 weeks. But I think the real challenge, Neil, John, you can agree or disagree. I think the challenge is education. It wasn't 2.5 years ago that I went to a program. John was part of it, Ralph Franzo, that we started talking about this ahead of the first part of the Catalyst trial. And I think back in my career, how many patients have we had over a number of years where we just have not been aware of hypercortisolism, thinking that Cushing's disease was this rare find. And I think the real problem and the real challenge in primary care is educating the clinicians. I have talked to my group about this. I've talked to my nurse practitioner who works with me and talked about looking and screening and how do we identify these people. And then I think the other challenge is to be sure, especially in communities where you don't have a lot of endocrinologists or really well-trained endocrinologists to handle this. Let's say you find hypercortisolism. You've done the test. You've seen it's ACTH independent. Then what? Okay, maybe you've even done the CT, but then what? Do you have someone that you can pick up the phone or contact and say, I need someone to see this? Because we know that in primary care, unless you're just a unique individual, we don't have experience using mifepristone. It's a very difficult disease state to treat, along with hypokalemia, steroid withdrawal. Where do we go once we have the diagnosis? And I think those are big challenges.
Using mifepristone is not for the faint-hearted. About, if I remember correctly, it was more than 40% of the people treated with mifepristone stopped the drug during the 24-week period, and mostly due to adverse events. The most common adverse events was this glucocorticoid withdrawal syndrome that happens with any cortisol-directed therapy. If we had done an adrenalectomy for one of the people with a tumor, they would have gotten that as well. It's a tricky condition to take care of. One of the most common reasons for coming out of the study was hypokalemia. In clinical practice, you would usually start someone on spironolactone at the same time you prescribe mifepristone. That's a more manageable adverse event, but it would behoove people to refer their first few cases at least to someone that has experience in using mifepristone. It certainly will make your life easier, and you can learn the ropes with those first few cases, along with an endocrinologist.
So it creates a challenge both in remembering to test, and then when you get that positive test, remembering what to do. And that's really why podcasts like this and other educational outreaches have been so important. John Buse, I remember in our first segment, you shared a case where the detection of hypercortisolism made really a pretty big difference in, similar to what John Anderson was referring to, in a broad set of areas in someone's life. Can you remind our audience about that case so we have a sense of the breadth of impact of detecting this?
Yeah. So this is a woman who I first met about 25 years ago. At that time, she just had metabolic syndrome, prediabetes, dyslipidemia, hypertension. She had a history of PCOS for about 20 years at that point of her life. And then I lost track of her. She actually moved out of the area and came back recently. At that time, she said that she had a stroke and then an episode of pancreatitis and was diagnosed with type 2 diabetes with a A1C in the 9.5 range. Started on metformin and then added insulin. At the time that I saw her, her A1C was 7.3. But the big thing was, in the 25 years that I hadn't seen her, she had turned over to someone with multiple somatic complaints, sleeplessness, different kinds of pain, depression, anxiety, hair loss. She had class 2 obesity, BMI in the mid to high 30s, weighed about 195 pounds. Her weight had been stable for quite a number of years, and she was on a total of 23 medications and supplements, including multiple analgesics, antidepressants, anxiolytics, 3 blood pressure medications. Her physical exam was pretty normal except for central obesity. She did seem anxious, and she had facial plethora. She was kind of red, flushed looking, and sweaty. And so we focused on trying to taper down some of her medications and juice up her anti-hyperglycemic therapy, get her established with glucose monitoring in a more consistent way, and did that for about 2 months, during which we were starting the Catalyst study. She didn't qualify for the Catalyst study because her A1C wasn't 7.3, but I did the overnight dexamethasone suppression test, and her cortisol came back 4. And 2 weeks later, and this was before we had the results of the Catalyst study, and I would talk to the local adrenal-oriented endocrinologists, and they just insisted we needed more testing than that. So we repeated the testing with a 0.5 milligrams of dexamethasone every 6 hours for 2 days, and still the cortisol was elevated. The ACTH and DHA sulfate were low, suggesting that it was of adrenal etiology. She had had 2 adrenal CTs in the prior year around the time of her pancreatitis. And so we know she didn't have any adrenal pathology. And eventually ended up treating her with mifepristone. Her A1C ever since then has always been less than 6.5. She's able to stop insulin. She is on metformin and empagliflozin, the latter not for glycemic control, but for her heart failure with preserved ejection fraction. She's lost 50 pounds over 7 months, and her weight continues to go down. She never had any glucocorticoid withdrawal syndrome. She's never had any hypokalemia, but we did treat her with spironolactone in advance. So she's done remarkably well with this therapy. It was a total game changer for her. And all of her somatic complaints and her mood are just vastly improved. That's what really, I think, the biggest difference for her has been.
Yeah, and
I'll weigh in on that as well.
Yeah.
I mean, we talk about all the glycemic parameters and blood pressure and weight. Truly, had he not diagnosed this, how long and how much misery would this person have gone through? Because in primary care, just like every physician and clinician I know, we really want to help these folks. And if we fail to recognize this in the right individuals, you're really never going to get them better. They're really likely to never feel better. You're really likely to never get glycemic targets, blood pressure targets, whatever, under control. And so I think as you start to talk to primary care, there's a really compelling reason to be looking for these patients.
Those are really wonderful and important points. We're about out of time. John Anderson, let me ask you to go first. Any final thoughts you have for our listeners?
For those of you in primary care who are really frustrated with patients with difficult to treat blood pressure, difficult to control diabetes, depression, all of the things we mentioned, you've got them on a lot of therapy. Put it in your box about let's check them for hypercortisolism. There is no downside to a negative dexamethasone suppression test. None, other than taking a 10-cent pill and coming in for blood work.
Really good points. John Buse, your final thoughts for our listeners.
Yeah, I'll double down on what John Anderson just said. Just screen people. I'm embarrassed to say, after all this Catalyst experience, I had a primary care doctor write to me and said, Dr. A has been a patient of yours for a long time. Do you think he might have hypercortisolism? And I just got his cortisol back today, and it was 4. So, yeah, just screen more people. You don't have to screen them every year. You don't have to screen them every 2 years. It's once. Just screen them once, unless they're doing very well with their diabetes.
Such an important point. Dr. John Buse, thank you so much for joining us. And Dr. John Anderson, thank you for joining us.
Thanks, Neil.
And most of all, of course, to our listeners, thank you for joining us in the third of a 3-part series on hypercortisolism in difficult-to-control diabetes, an emerging concept with a lot of excellent evidence from the Catalyst study to support it. This is an exciting advance in the diagnosis and management of people with uncontrolled diabetes. Remember to screen. Think about screening for hypercortisolism in people who have difficult to control diabetes. This special series of Diabetes Core Update is sponsored by Corcept. We thank you for listening. For the American Diabetes Association, I'm Dr. Neil Skolnik. Till next time, stay safe and keep learning.